Okay, this is great. Good morning. I'm Bob Schwartz, your host for this Stoneleigh Foundation virtual convening, Fellows in Action, Policy and Practice Implications of the COVID-19 Pandemic. The Stoneleigh Foundation's mission is to improve the life outcomes of youth by advancing change in the systems that serve them. Stoneleigh supports fellows, believing that talented individuals can change the world. This morning, we will hear from 4 of those fellows, 2 in healthcare, Meredith Matone and Nadia Dabushin, and 2 in juvenile and criminal justice, Adam Sullivan and Sangeeta Prasad. A word about our format. Fellows will first introduce themselves, their projects, challenges that existed pre-pandemic, and how COVID-19 has affected the youth they serve in a way that's distinct from the general population. We'll then have about 15 minutes as I ask a few questions for panelists to go deeper into the impact of the pandemic. Then we'll have time for questions from you, wherever you are. And at the end of the hour, Stoneleigh President Ronnie Bloom will make a few closing remarks. So now Stoneleigh's Mark Hauk will explain the logistics of this event. Mark?
Hello, everyone, and thank you for joining us. We will be setting aside some time at the end of today's discussion for audience questions. If you have a question for any of the speakers, please click on the Q&A button at the bottom of your Zoom window and type your question into the box that appears. When you ask your question, please include your name and organization so that we can identify you for the speakers. Thank you, and please enjoy today's convening.
Okay, we're going to have a run through of the speakers, about 4 or 5 minutes each. Beginning with Meredith Matone.
Great. Good morning, everyone. My name is Meredith Matone. I'm a Stoneleigh Fellow, the Scientific Director for Policy Lab at CHOP, and also a faculty member at the Penn School of Medicine. Tell you a little bit about my fellowship and make some remarks on COVID. So the goal of my Stoneleigh Fellowship was to take a look at the role of maternal health in intergenerational cycles of maltreatment among adolescent mothers specifically, and also to understand the impact of maternal and child home visiting services in interrupting intergenerational maltreatment within families. So as an epidemiologist by training, I took a research lens to this fellowship and created a data set that linked across health, child welfare, and service enrollment. What I found in this work over the past 4 years is that for women experiencing early entry into motherhood, mental health and substance use challenges are common. Adolescent mothers in Philadelphia are at high risk for depressive and anxiety disorders, as well as externalizing and behavioral conditions, and may also be more likely to be affected by substance use disorders. And a particular challenge occurs in the postpartum period where we are seeing that engagement in the healthcare system is a steep cliff for young women with a lot of unmet need for care, leaving them vulnerable to adverse outcomes both for themselves and for their infants. With regard to home visiting, while home visiting services are effective at engaging young mothers, and particularly in this postpartum period of risk, we're seeing that before COVID, there's still room in our service delivery infrastructure for better alignment across home visiting services, healthcare, mental health and substance use, and also domestic violence services to really have sort of integrated care to meet mothers' needs. And acutely in this time of COVID, under the stay-at-home order, access to infrastructure and preventive service has really become a challenge. And we know this is a period of heightened stress and service disruption, and I in particular worry for the mental health and safety of young mothers and their children. And we've seen increases in domestic violence among youth, and anecdotally have also seen some evidence of emerging mental health crises. I also want to raise the issue of sort of the well-being of support networks for adolescent mothers and their families. We know that many young mothers rely heavily on multi-generational family support networks that may be impacted by the health or socioeconomic impacts of COVID during this time.
Okay, thank you. We'll go deeper into that as we move forward. Nadia.
Good morning, everyone. I'm Nadia Dabushin. I'm a pediatrician and adolescent medicine specialist at Children's Hospital of Philadelphia. And I'm the medical director of our adolescent HIV clinic, as well as the co-founder and medical director of our Gender and Sexuality Development Clinic, which serves over 1,500 transgender youth and their families. I'm also on faculty at Policy Lab and at the Penn School of Medicine. And my Stoneleigh project focuses on trying to improve access to care for transgender youth, and particularly an action research project that is youth-driven for young transgender women who are at extremely high risk of HIV infection, to be part of evaluating services that they receive for HIV prevention. So our plan is to have a group of young people who would be going to do mystery shopping visits at clinic sites to understand the quality of care that's being provided, and then for them to be part of evaluating that care and providing feedback to organizations across the city that are providing HIV prevention care and making sure that it's done in a way that's gender affirming. However, as you can imagine, that project may look very different given all that's going on with COVID right now, and the fact that most medical care that is not considered urgent or emergent right now is not happening in person, and it's likely that much of that care will continue to not happen in person over the foreseeable future. In general, the young people that I care for, those living with and at risk for HIV, and those and youth, specifically youth who are transgender, are a group that have had many challenges in accessing healthcare prior to the COVID epidemic, and many challenges with prioritizing healthcare due to other competing needs in their lives. As Meredith touched on as well, for the population of youth that her project is focused on. So one of the things that I've noticed in my talking to many of the young people that I care for during the COVID crisis is that many of them are the essential workers on the front lines. And not only is this a challenging time for them to be receiving healthcare services and accessing other services that they need, they're also they are the folks who do not have the privilege to socially distance during this pandemic, making things even more difficult for them. So I look forward to talking more about some of the solutions later. That the way that I have gotten to talk to my patients during this time is through telehealth, and we'll talk more about the promise of that later.
Okay, thank you, Nadia. Adam.
My name is Adam Serlin. My fellowship is in partnership with the Center for Government Excellence at Johns Hopkins University, and I'm also embedded at the District Attorney's Office here in Philadelphia. Prior to my fellowship, my career was in community-based juvenile justice, specifically running alternative to placement and alternative to detention programs. For the first part of my career, I swore I was, one of the good guys, keeping kids out of placement, keeping them out of secure confinement. Eventually, I started to realize that a lot of kids ended up going to placement or detention from my programs. So I started to ask some questions about, were my programs working? How were kids doing, both while in my programs and after my programs? And through some research, started to realize that there's no real performance-based contracting in the juvenile justice system here in Philadelphia. All of our programs are per diem funded. So we were all being paid per kid per day and not really being audited on what we were providing in terms of outcomes. So I started to track some outcomes and got a fellowship, and I'm currently working with the District Attorney's Office to kind of build a database and work through how to track cases from the beginning of the system to the end of the system and benchmark outcomes to try and drive policy change and better performance management in the system. Specific to COVID, I think an interesting thing that I've been thinking about a lot recently is that we're all kind of getting a little antsy now with the shelter-in-place orders. And everyone wants to go outside, wants to go back to work, go see family, go see friends. This specific emotion is not necessarily something new in the juvenile justice system. So we focus a lot about kids being in the deeper ends of the system, placement and secure confinement. But every single community-based program or mentorship program inside of the juvenile justice system here comes with home restriction as an option, if not mandated. So in-home detention, GPS, evening reporting centers, intensive supervision programs, they all have mentorship, but as part of it, all kids are confined to their homes, and anytime they leave their home, not to go to school or not to go to an approved probation activity, it is considered a technical violation, and the more technical violations kids accrue, they go deeper into the system. So, you know, as we're all kind of getting a little antsy and wanting this thing to end, it's interesting to think that some of these kids have had 2-month, 3-month, 4-month, 7-month, 8-month head starts on, you know, home restriction that we're all feeling right now. And obviously once mentorship gets cut from that and kids can no longer go to school, there's this sense that, you know, at some point in time, kids are going to feel frustrated about, I was supposed to be off of these programs. I was supposed to be able to go outside. Will people be able to, you know, conceptualize what's happening? Is this the fault of the system, or is this just society theoretically letting me down again? I want to be out of these programs. Same thing with kids in detention, awaiting placement, right? If placement facilities are now requiring negative COVID tests to accept a kid, then your length of stay in detention is ballooning. Same thing in placement. If you need a safe place to go home, and now there's medical issues, you may stay in placement longer. So I'm curious to see, you know, how frustrations of children for being in programs for extended periods of time may ultimately lead to certain behaviors or non-compliant behaviors or getting fed up with programs and going outside, and how the system will ultimately deal with that when courts do resume, and if there's going to be a break for some of these kids given, you know, kind of the broader context of what's going on, or, you know, will violations continue to be violations, or how we will resume to try and get things back to normal at some point in time.
That's good. So we'll be going deeper into that as well. Sangeeta.
Sure. Hi, good morning, everyone. So I, like Adam, am hosted by the District Attorney's Office in Philadelphia, and the majority of my fellowship is aimed at reducing the population of young adults and all adults on supervision in the city of Philadelphia. Before this COVID pandemic, people in Philadelphia faced several challenges related to the city's over-reliance on the criminal justice system, sentencing, and probation supervision. So before this pandemic, Philadelphia has and had the highest rate of incarceration in the US and one of the highest rates of supervision. So for comparison, Philadelphia has 4 times the incarceration rate of New York City and about 6 times the rate of supervision compared to New York City, given the population of the 2 cities. So before this crisis, before the shutdown of the city, there were about 4,500 people in the county jails and 37,000 people under supervision of the Philadelphia Adult Probation and Parole Department. At any given time, between 40 and 50% of the county jails are filled with people who are being held on a detainer for committing a violation of probation. You add to those challenges the fact that we are the poorest large metro area in the United States. So prior to the pandemic, people were faced with the challenges of this over-reliance in that they were frequently found to be in violation of probation and detained in jail for violations, even if the behavior was not a new crime. So the unique ways that people on supervision are being affected now that we are in the midst of this crisis is that we have people being held in jail for violations of probation, in some cases not activity that is a new crime. And some are able to get emergency hearings, but they are not able to participate in those hearings. They are telephonic hearings. It's either the judge and defense and prosecution by phone, or I believe they're trying to work towards videos as well. But if you are sitting in a county jail, you are not able to participate. The idea is that the defense has spoken to you about all the relevant arguments that could be raised for your release, but at this point, a significant number are not being released. So uniquely, there are folks sitting in jail who have not committed a criminal offense and do not know when they will be able to have a hearing before their judge that is not an emergency hearing and will allow for them to be released. The second way that the probation population is seeing a unique challenge is that they are more likely to not be able to meet the terms of their probation. With every probation, there are terms such as paying fines and costs, paying restitution, maintaining employment, being able to complete education, and all of those terms and conditions currently are not able to be met because there are so many service providers and so many employers that are letting people go or not able to provide their usual service. So for this population, there is the unique stressor hanging over their heads that they're in violation of probation and may in fact be locked up as a result of that. And because the criminal justice system entangles African Americans more disproportionately than any other population, our African American communities are suffering these unique challenges to a much greater extent.
Thank you. I'm going to ask for the next couple of questions, at least two of the panelists to take the lead. And while you've touched on this, I think each of you, I'd like us to take a look at the pandemic's impact on the service delivery infrastructure with which you work, and ask Meredith and Sangeeta to take this on in terms of what are some of the systemic barriers or challenges to serving your population in view of the pandemic that the system has to face, so that people in charge, whether it's in the justice system or Meredith, beginning with you in healthcare, what changes do they need to make, and have they been making them? So Meredith, you're still on mute. So Mark, if you could get her off mute.
Sorry.
There we
I
go.
wanted to make sure you couldn't hear my toddler in the background while others were talking. So I think the first sort of major system to acknowledge when we're talking about adolescence is the school system. And obviously under stay at home, there's been a disruption in access to school and the school environment. And I think there's a lot of work to be done in terms of understanding not only how to reopen school and how to maintain engagement for high-risk youth for whom engagement in school was challenging prior to COVID. And now there's been a number of life changes that have inevitably happened to youth over this period, and making sure that we get them back connected into school or other sort of educational support programs on the other side of this, I think is really important for the educational, economic, and overall sort of well-being of the youth population. I think for adolescent mothers in particular, in terms of the service delivery environment, services like home visiting and early intervention have transitioned to telehealth, which I think there's a lot of promise in maintaining connectivity with families virtually. There are logistical challenges though, and I think those logistical challenges include technological literacy, I think just technology access for families. For some families in multi-generational households, there may be only one or two cell phones shared amongst many family members. And so for a service like home visiting or early intervention for young children, that is sort of really going to require that device for a half hour, 45 minutes, 60 minutes, that can present a logistical challenge for families. And we're seeing that a little bit in terms of home visits or other sort of types of mental health and other consults sort of being abbreviated from their normal duration to maybe 10 or 15 minute consultations. I will say though that the early childhood community in general, so home visiting, early intervention, some childcare facilities have really been making heroic efforts to maintain connections to families in whatever way they can. And I think that's incredibly commendable. Maintaining connections and support for youth during this time is really important. And I think while there's likely been some sort of sacrificed quality and access to those services, overall, I think there's a lot of work being done and work that I think holds promise for sort of sustained sort of implementation following COVID in terms of more flexibility for unique ways to engage with families that are hard to engage with. So I see that as promise. The other point that I wanted to raise about the service delivery infrastructure is around demand for services and what we might anticipate in terms of demand for preventive and social services, as well as sort of safety net services that have an income-based eligibility. We anticipate that there are a lot more families that will likely be eligible for income-based services due to the changing economic circumstances for individuals and families due to COVID, with higher rates of unemployment and furloughed employees. Demand may exceed capacity of these services. And in fact, prior to COVID, we know that for a lot of our community-based programs and social safety net programs, demand was already exceeding capacity for a lot of our programs. And so I think as we think about the future and these programs, really taking a hard look at the sort of service delivery infrastructure and its capacity and what sort of changes may need to be made in order to meet the needs of the sort of changing landscape of the economic circumstances of communities and services in which they are likely going to need to rely on.
Good, thank you. And I suspect that capacity issue will be a theme that runs across all the sectors here. Sangeeta, what are the service delivery infrastructure issues that you're confronting, and how has the pandemic affected them?
So one of the ways that I was meeting my goals under the fellowship was to actually have a cadre of judges, about 9 judges, providing criteria for early termination from probation and actually terminating people early. In essence, it's a version of good time, with each judge determining how they establish what good time is. We have probably between 50 and 70 petitions waiting to be filed or have already been filed that cannot be heard because the courts are now, the criminal courts are closed through May. So the only hearings that are occurring are the emergency hearings that I alluded to earlier. And the basis for getting an emergency hearing is if you have bail issues after the defense and prosecution have reviewed the matter, if you're nearing your parole, or for a select few people who are sitting in custody if you are detained for a violation of probation. If you are out in the community and serving your probation and doing everything well, you cannot currently get an early termination or in fact any kind of termination. So the threat of violating that probation hangs over your head if you're in the community. For those who are in jail, if you are granted that emergency hearing, as I mentioned before, you're not able to participate in it. You're not able to provide witnesses. I should say, though, that in the last 4 weeks, there has been about an 18% decline in the number of people in custody. Not all of those declines are due to the emergency hearings. It is in part also because the arrest rate has gone down for certain types of offenses. But given that decline, it does beg the question, did those folks need to be in jail to begin with? Again, we are the most incarcerated large city in the US. So with that decline, you can say that these emergency hearings are having some impact. There is some effect. But for those who do not get the hearing or are not released as a result of it, they are going to be in prison, in jail, and much more likely to get COVID and to spread it. So the impact is not just on their mental well-being, it's actually on their physical health, which is a pretty frightening prospect. So if you violated your probation, you certainly didn't think that you were going to be subject to a very contagious virus with a very high mortality rate. That should not have been part of what your punishment for violating probation is. And then for the folks who are out in the community, as I mentioned before, they're going to be much more likely to be fired, furloughed, and underpaid. So while they're trying to meet their terms of probation out in the community, they can't quite do that in the same way that the general public can, because the probation department is not doing check-ins with folks. They're not connecting them to new providers. Essentially, everything at the probation department is in standstill mode. It's stopped. And that's the case with several of our other city agencies as well. But given that there's 37,000 people relying on the adult probation and parole department to allow them to move through their term of probation with some rehabilitative aspect. I think this stopping of services from probation and parole is going to have a huge impact on those who are probationers. In essence, people are really left without the supports, and they're left in circumstances that increase the possibility of their being found in violation when this crisis is over or when we begin to reopen.
Well, thank you. That's discouraging, to say the least. I'm going to turn to Adam and Nadia now, just to take a look at sort of unexpected or unforeseen opportunities that have arisen, either in terms of new knowledge, new understanding of the challenges that you're taking in your respective areas, or in how the systems might have stepped up to be more effective in the work they're doing. So if you could take a look at that, and also sort of weighing in the background, at least for me, are issues of risks. You know, as opportunities arise, kids are at risk if they take advantage of them on occasion. So if you could at least touch on, if you have a moment, on how risk affects new opportunities as well. So Adam, why don't you begin?
Yeah, Bob, to touch on a point that you had talked about a little bit earlier in terms of capacity, right? If you're redesigning a system or any type of social innovation, you're like looking for things that have high impact, high value, and are scalable. And there's always been, you know, we know through all types of statistics, right, that kids in the juvenile justice system are overrepresented with behavioral health and mental health and untreated mental health issues. And there continues to be this lack of psychiatry time and therapy time and long waits that have continuously kind of driven bad outcomes in the juvenile justice system. And I think that, right, the answer is not necessarily for every community-based provider to hire more psychiatrists, to do in-person visits, because that hasn't necessarily proven scalable yet. So I think this concept of, you know, telehealth and telemed that people are kind of shifting to during these times could be a really big factor in improving the juvenile justice system moving forward. So I'm not sure how familiar everyone is with the process of juvenile justice, but when you get arrested, you don't just get referred to a court hearing. 100% of kids who enter the system go to an intake conference with a probation officer where there's a questionnaire given, and that questionnaire has questions related to behavioral health and mental health issues. I took a look at some of those just to prepare last night. This is not quotable, you know, numbers are subject to change. I'll throw out broad numbers, but looking at, you know, about 900 of these, you know, roughly 35% of kids and families self-reported an ADHD, depression, or bipolar diagnosis at that probation intake interview. 18% of kids reported one of those diagnoses, roughly, and were not connected to therapy or medication at that point in time. And so that is at the very, very beginning point of the system. We know there's about 6 kids arrested and charged in the city of Philadelphia daily on average. So about 1 kid a day would be showing up to the Juvenile Justice Services Center and saying, you know, I have a diagnosis, and parents, I either have ADHD, bipolar, depression, and I'm not currently receiving therapy. I'm not currently on medication. And that's all the way at the beginning, right? We can talk about the deep end problems of kids being released without medication, or kids' insurance getting cut off when they transition out of placement to back to their homes. But the question is, what are we doing with these kids who self-identify upfront when they're literally in the possession of the juvenile justice system at an intake conference and reporting that they have these diagnoses? Currently, the answer is like really nothing. So if the parents say, I'm not going to take this kid home, they're out of control, a kid can get held in detention. And that's kind of a secret throughout the juvenile justice system that everybody knows, that it's about 30-day wait at best if you get referred to a community-based provider for psychiatry. If you get held in secure detention, you can get a behavioral health evaluation in 2 weeks. So the quickest way to get evaluation is to hold a kid in secure detention. So maybe some kids take that pathway. If kids get released back to the community, they're going to get, with these same diagnoses, they'll get a 2-week pretrial date on average. And in 2 weeks, the DA, the defender, and maybe if they're on some sort of a supervision program, people will meet in a courtroom. The kid might get an offer. they're probably not going to get referred at that point in time to outpatient treatment because they're not adjudicated of anything. So people want to reduce the number of terms on the kids. But even if they did, you're 2 weeks out, they would get referred to a community-based provider. Maybe 30 days from then, they would get some sort of an evaluation. If they're in therapy, there's lack of therapy time after school hours. So they may be missing school to go to therapy appointments. If it's once a week, say they're in 3 months of therapy, you've now missed, what's that, 12 days of school at minimum. And so you're at that point in time, a month and a half out at best with a kid coming into the system, self-reporting a diagnosis with no medication, who is now being asked to go to school every day, stay in their home, comply with their family's rules, comply with their probation rules, don't smoke drugs, any of these things. And anything that is non-compliant about them will lead to a higher level of care, when really it's probably them acting in direct accordance with what they reported at the very front end of the system as being an untreated diagnosis. So if there are ways to use telehealth to kind of get assessments and kids access to treatment and medication instead of in cutting through some of the slog of delays, and a probation officer then needs to read the notes, or a DA needs to read the notes that was written at an intake conference and then refer to an outside agency who then needs to, schedule time. We're losing a ton of time and kids are racking up non-compliance. So, and the same would hold for kids coming out of placement facilities. They're not any longer given 30-day scripts of their medication because, even Adderall is considered a narcotic now. So, where they used to get a 30-day script, they're now coming out of placement facilities and coming off of their medications while expected to comply. Sometimes their insurance is cut off. So telemed could be, an Occam's razor cut straight through a lot of these technical issues that we can hopefully expand upon if after this pandemic, some of the HIPAA restrictions remain lifted however they are, and billing is enabled to happen. So I'm sure Nadia.
We need to take a look at that. Yeah. And that's really important. It's actually a great segue because, Nadia, I'm assuming that you're dealing with telemed and telehealth issues in the ways that the juvenile justice system is not. So, but what opportunities there or elsewhere have you seen or identified for the world you inhabit?
No, absolutely. So Adam set it up great for what some of the potential opportunities are for telehealth. As somebody who had been doing a lot of research about using technology to try to improve access to care and outcomes for youth living with and at risk for HIV, telehealth was something that I always hoped would be an option. But unfortunately for children in Philadelphia in general, it has not been an option in the past. And that was primarily due to the issues around lack of reimbursement from insurance companies, and due to some of the state laws and issues around privacy. Also to speak to some of the issues that Meredith raised around some of the barriers to telehealth in relation to digital access and the digital divide. One thing that we have found for many older adolescents and young adults and the populations that I care for in our studies is that even if kids don't have food to eat, or they don't know where they're going to be staying next, most of them have a cell phone. And they really do prioritize that, and they'll find a way to keep it on. And if one gets lost or stolen, they'll eventually get a new one. And so we have been doing a lot of work in the past to around text message reminders and engaging youth through apps to try to get them to take care of their health that way, because we know that those phones are in their hands all the time. So we should use them as a tool to help them to make their health better. So I had always been looking forward to the opportunity for telehealth for these populations of marginalized youth that I serve, but it was previously impossible. And then, with the COVID epidemic, our outpatient clinical care at CHOP was pretty much completely shut down as soon as it looked like stay at home orders were coming into place. And we were suddenly encouraged to do something that we weren't able to do before. We've had now about 6 weeks of having telemedicine up and running in our adolescent specialty clinic. And it's been really amazing to see what the opportunities are there. And we've conducted something like 500 visits. And we've actually been able to analyze some of the data already that are showing us that despite there being differences in race, socioeconomic status among patients and being served by our clinic, there's been pretty equal access to telehealth, and the rates of show at visits have been equally as high for those who are economically marginalized, which is really encouraging. And my sort of personal anecdote about that is that for my clinic for youth living with HIV, because these young people have so many competing needs and barriers to accessing healthcare, they often just aren't able to make it into their visits. And since we started doing telemedicine visits, the first time I had a clinic, I had 100% show rate, and that was really the first time that I had ever had that, and in a very, very long time. And we are continuing to see over time that it's certainly not a perfect system, but we are getting higher rates, higher show rates and rates of engagement, because we're making it more convenient for youth to participate in care with us. I think also, speaking particularly for youth who are transgender, I noticed that when we have visits by telemedicine, they just seem to be much, much more comfortable. These are young people who often experience a lot of discrimination or hate within the healthcare system. And they can have to travel far distances to get to our clinic. And even though our clinic staff are well trained to be supportive of young people regardless of their gender identity, we don't know who they're going to run into on the street or in the elevator, and how people might look at them, or whether they may feel uncomfortable with the options about what bathroom they have to choose to go into. And so when we're able to talk to young people through telemedicine, they're in a space, they're in their home, they're in a place where they're much more comfortable. And so we're able to have a different kind of conversation, and they don't have to, be as nervous about what might be coming at them when they arrive at the clinic. So there definitely have been a lot of advantages that we've seen. Certainly there are many challenges as well, in terms of there are some folks who don't have the technology access, and there are certainly also privacy concerns. We always, in adolescent healthcare, it's a huge issue that we know that youth will not get the ideal care that they need if they don't have space to have confidentiality around mental health care, substance abuse care, sexual health. And so we have to be, really certain that we're able to create that kind of confidential space through telehealth, which is certainly more of a challenge. And that's just involved, now having conversations with youth and parents at the beginning of the visit to say, I can't just kick you out to go down the hall or back to the waiting room like I used to. Now we have to figure out how we're going to do that in the context of your home. And we've been able to figure it out so far. And also with the electronic medical record, we've been really lucky to work with our IT folks at the hospital to make sure that we're not releasing other private information through the patient portal that youth access care through, but talking to folks in other clinics within the city and nationally. For many folks, telehealth does come with that risk of potentially disclosing more information that youth would want to keep confidential. So I think ultimately a lot of opportunities that we can get more care for youth during this time of COVID, but also to get more of this kind of care after this crisis for the youth who need it.
Thank you. I mean, you've all identified some themes here that seem to be cross-cutting. And while your projects are all different, it strikes me that in one sense there's a synergy among them, but also some themes that where you could learn from each other. I mean, the issue of confidentiality, the issue of being an outpatient or on the street on probation or parole are sort of similar classifications. And I'm wondering, I'm going to go through each of you, if you could do in a minute for an answer. What has struck you about the presentations this morning that suggest an area of commonality that we could build on? So Sangeeta, we'll start with you, then go to Adam, Nadia, and Meredith.
Sure. So I think it would be incredible to have telehealth facilities and capabilities in the jail and prison system. I think that would increase the number of people who are able to provide relevant information for these emergency hearings and be able to be released as a result. Because COVID has been shown to be a higher mortality rate, obviously, for those with underlying conditions. And so many people entangled in the criminal system have more health conditions, such as diabetes, high blood pressure, et cetera. So I think telehealth in the prisons or jails would be great. It also occurs to me that this brings up that the way that the criminal justice system operates should be analyzed through the lens of public health. Because if you're holding someone in jail who's not a threat to the public, you not only increase their stress, decrease their mental health, but you increase their likelihood of catching the virus and spreading it. On that note, if we were to have more technology in the jails, and if we were to put more technology in the hands of people who are on the street and potentially serving probation, I think, in fact, this could be an incredible opportunity to not only create more equitable standards for getting healthcare, but all of the positive results that would flow from that.
That's great, thank you. Adam, briefly, what do you see as cross-cutting?
Yeah, I think that COVID has kind of introduced some level of, everyone wants to help now because there's a COVID crisis. And I don't know how many necessarily brand new crises it's created as much as it's like amplified existing inequities that have already happened. And it is interesting, maybe there's this point in time where people are actually having the empathy required to make like a human-centered design of a system to deal with some of these issues across all of these various sectors, because our kids or our whoever the clients maybe are touching so many different services. And now finally, it does feel like this pandemic, everyone is very, very worried about all of all the populations in light of COVID, and hopefully some of that carries forward a little bit to highlight some of the issues that this is amplified. And I guess just, Meredith was talking about building data systems across systems, and we're still pretty far behind in that capacity. So that's a huge area where we need to improve to do some of that.
That's excellent. Nadia, your thoughts?
Yeah, I think also one of the areas of overlapping opportunity that folks have touched on is to rethink our systems of congregate care for youth. So whether that be juvenile detention, shelter systems, group homes, mental health, inpatient mental health facilities. And again, this is something that I'm seeing for myself and for my colleagues on the front lines. Our adolescent medicine group is responsible for providing services at Covenant House Youth Shelter in Philadelphia, as well as Belmont Inpatient Mental Health Unit for Children and Adolescents. And we also, my adolescent HIV program has a relationship with the PJJSC in terms of providing support services there. And so we're
and that's the detention center, right?
Yes.
Yeah.
And so we're seeing at each of those places the incredible challenges that the clinicians on the front line are facing to keep kids healthy and safe during this COVID pandemic, and for their staff as well. And so I think that, this is a time that we're understanding one of the very big limitations and problems with having youth in these settings, and that we should be using this as an opportunity to rethink how those programs are working.
Great. Thank you, Meredith. And then I hope we'll have time for some questions as well from the audience. So Meredith, you have the last word on this.
Sure. I mean, I guess, I agree with everything that my colleagues have said. And then what I would add is I think we heard sort of a thread of mental health throughout. And I would hope that this is an opportunity for a real sort of paradigm shift in how we prioritize mental health of our young people, and acknowledge the intersectionality of mental health with early entry into childbearing, with systems involvement, with educational outcomes and attainment. I think often our systems view mental health in a reactive way, rather than seeing the opportunity of mental health as sort of a primary prevention strategy for adolescents, and taking sort of that life course prevention lens and viewing mental health really as the core to set youth up on a trajectory of health and well-being. And I think that throughout COVID and everything that we've sort of seen has really highlighted both the need and opportunity to recenter all of our systems, and I would argue all of our engagements across any system: health, child welfare, juvenile justice, obstetrics, community-based settings. Any engagement with youth should prioritize and take a lens of mental health. It's so critically important, and I think it is sort of a central risk factor for many of the work that we do on the back end. So we can improve our back end systems to make sure that our juvenile justice system, our child welfare system are more youth-centered, trauma-informed, and but really I think we should move upstream and try and prevent engagement in those systems to begin with. And I think there's an opportunity now that we've sort of experienced this collective trauma of COVID to refocus that conversation.
Okay, thank you. Mark, do you have questions that you'd like to bring in from the audience?
No, so we do not have any questions from the audience yet, but we may shortly, now that we've moved on to the Q&A portion of the event. I will raise my hand to let you know if we get anything in, but for now, if you have any other questions for the panelists.
Well, Meredith, you just mentioned child welfare among the systems, and we haven't really touched on child welfare. And I'm wondering whether any of the panelists have seen a different interface between child welfare and your clients, whether it's those in the justice system. For Adam and Sangeeta, if you have kids who are still Sangeeta of age, or Nadia and Meredith, kids who might otherwise be in touch with child welfare as well. How has this pandemic affected their interaction with you?
So I think it's kind of interesting, right? With juvenile justice, child welfare stuff raises, like with congregate care, a huge issue because kids can't be released out of facilities unless there's a place for them to go. And obviously now, everyone wants kids released out of facilities because of COVID. But the more fundamental question is, like, why are dependent kids in a lot of these facilities in the first place? And the issue of them not having a place to be released is not new to this pandemic. There's a new driver of urgency because everyone wants them out of the facilities because of the pandemic. But I think we need to maintain that, say, like, it's immediately, we got to get the dependent kids out now because they shouldn't have been there maybe in the first place. So now there's a driver of this thing, but the issue of kids not being able to be released without a place to go home and no one providing a proper place for them to go home is not new at all to this pandemic. Everyone is just now kind of driving the train a little bit harder because there's a chance they might get sick in a placement, whereas like before they might get beaten in a placement or abused in a placement, or they still miss home anyway. So it's kind of interesting to me in that way.
Nadia or Meredith or Sangeeta? Go ahead, I see.
So there's been a significant number of people under 18 who have been deemed having committed an offense serious enough that they go directly into an adult jail. And in the adult jails right now, the isolation that is happening in order to try to prevent the spread of COVID is going to be even more impactful for a person under 18 who is sitting in an adult jail where I would say that they should not be in any case. And a vast majority of them have had involvement with the child welfare system. So I think a little bit of what Adam said holds true for those young people too in the adult system, is that they have even less access to the services they might have needed and the supportive connections that they might have needed.
And Nadia and Meredith, do you want to touch on this? Because I would imagine that the child welfare system does have some connection with some of the families or children with whom you work.
Yeah, so many of the young people that I care for are currently or were previously involved in the child welfare system. And I think that, in general, especially for those I'm taking care of, usually the kids who are more in the realm of aging out of care. And that's always been a time where young people have been at risk of losing access to care and to services. And I think that, only becomes exacerbated now when they cannot do a lot of things that they used to do in person. So it's certainly, very concerning to me in that way.
Meredith?
Yeah. I would just reiterate sort of the high engagement. About half of the adolescent parents in Philadelphia have past child welfare system experiences, and many of the families that are receiving home visiting services are also engaged with the child welfare system as well. And I think, the child welfare system sort of operations have slowed a bit. There's been a lot of work to sort of prioritize and stage sort of triaging child welfare operations. I think some families have had some disruptions in supervised visits and sort of the court processes that are needed for processing reunifications and other sort of things of that nature. So I think there are some families of young children who have been impacted by sort of slowed child welfare operations, which creates added stress, I would say, at a minimum for families during this time.
Okay. Mark, I see you have a raised hand.
Yes, so for our first question, Cameron McConkey from YHEP says, thank you all for this dialogue. As we talk about some of these shifts and opportunities in systems, if not their total redesign, I'm wondering how we can include and organize youth in this process. Nadia, I know you are evaluating youth experiences with telehealth. Does anyone have ideas about ways in which youth inclusion in the system change can be prioritized?
So, Nadia, you were mentioned. Do you want to start with that?
Yeah, thanks, Cameron, for that question, who's one of our amazing Stoneleigh Emerging Leader Fellows working at YHEP and Philadelphia Fight, where they're doing incredible work providing access to care for youth. And I 100% agree that the involvement of youth in the solutions to their problems is so key and has been missing from so many previous efforts to improve health and well-being outcomes for marginalized youth. I think that the project that I'm doing for my Stoneleigh Fellowship, the research project, really is about empowering young people to be part of the process of evaluating their own healthcare, gaining skills to understand healthcare, so that if they want to work in that field in the future, that they can be part of transforming that system to better meet their needs. And I think that as folks across the city who are leading on policy in different areas and thinking about their responses to this crisis, that we really should be including youth voices and having them be part of those policy convenings to ensure that things have the impact that youth want them to have and that we want them to have.
Thank you. I know that this could be a topic for an entire other webinar, and maybe we could flag that for Stoneleigh. But Mark, you have one other question coming, and why don't we make that our last one before we turn to Ronnie?
Sure. So we have one more question. This is from Dana Schoenberg, I believe at Pew.
Yeah.
What are your recommendations for administrators and judges who are thinking about releasing youth from facilities at this time? Given that community-based services are limited, what can courts and juvenile justice agencies do to be creative about their support?
Yes, and I would add just there's a risk issue there as well, you know, in terms of who you're releasing to and what you need to know. Adam, you hinted at that earlier, you know, being beaten versus getting the virus. So, you know, taking that question, Sangeeta or Adam?
I would just say that you would want to ensure that that young person has access not only to a cell phone, but to an actual laptop, and ensure that they have a connection to the services that are available right now, because several are active, several agencies and organizations are active, but they're doing everything virtually. So before that young person is released, ensuring that they have an understanding of and the equipment necessary to participate in getting services in the way that they're available right now, in the limited way.
Adam, do you have a word on that before we turn to Ronnie?
I also think it's interesting, right? Even the notion of risk and and needs, like we need to kind of define at risk for what, and are we being, right? Is it at risk for public safety? Is it at risk for non-compliance? All those things I think need to be examined a little bit, because I do think we do a lot of things to protect our kids from risk that ultimately end up damaging them in the long run. We do it to girls in the system all the time, holding them because maybe they're going to run away from home. We do it, you know, repeatedly. So I guess the question is, you know, what are we looking at in terms of risk? Is it risk of, you know, absconding? Is it risk of running away for a weekend, or is it risk of committing another offense? And I think that those things might need to be separated a little bit, and it may be an opportunity to think about separating those things a little bit in terms of, you know, how long do we hold kids in facilities to protect them from some sort of risk, and what is the risk we're trying to protect them from?
That's great. Thank you. Thank you all, panelists, for your time and the energy you put into this webinar. Ronnie Bloom, President of Stoneleigh, has some concluding words.
Hi, everyone. It's great to see you all today. First of all, I just want to thank Bob and thank the panelists for sharing their insights with us today. I'm sending you a virtual round of applause, let me put it that way. And of course, I want to thank all of you out there who have tuned in to us for participating, bringing people together for conversations like these sort of virtual convenings that help, I really envision solutions, as well as defining the problems that we all see around us related to COVID-19. We see that as a really critical role for us at Stoneleigh. So thank you all for being with us. And I do just want to let you all know that we will be having a second one of these virtual convenings on May 14th at 11 o'clock, Thursday again. So we hope to see you then. Keep your eyes open for the invitation. And until then, I wish everyone the best and stay well. Take care.
Thank you. Thank you, everybody. And we're off the air.